Well, that was just an amazing series of talks that I think make the discussion part to really talk about trial design and how to really think about getting more data to support use of this and how to use it in the setting of solid tumors. I mean, so we heard some amazing talks, really, I think that set up best principles and how to approach this, looking at a wide range of solid tumors. And I mean, some of the themes that I heard, and so key is clinical hypothesis, that it goes in with a science-driven clinical hypothesis about the tumor type and how to treat. One of the things that I think has been really challenging for folks is as we talk about the disease as a whole, like even the beautiful presentation from Dr. Lim and really characterizing the macrophages, do we need to think about that in terms of a readout for what's the heterogeneity across the patient populations? Because as we see these changes and tumor tissue is very difficult to get in sufficient quantities to answer lots of questions. So making sure we have the primary question there to be able to characterize that and then see if the modulation has taken place. I do think there's a lot of exciting work in circulation, being able to show modulation of many of the cell types of interest, even if they're rare populations like dendritic cells. Macrophages are obviously something that you really do need to look in the tumor. So overall clinical hypothesis, then setting up the endpoints. I mean, I did think it was interesting in Dr. Jones' presentation that he did include secondary endpoints with immune readouts. And that always has challenges in terms of defining success and in the statistical analysis plan. So really thinking about how those things are going to be set up, I think take a lot of discussion so that it can be interpreted. And then I think a theme across a lot of the talks that we heard is also on trial design and patient population. So not as sexy and fun, but really practical in terms of being able to recruit and think of the timing. So I think maybe from some of the questions as people were talking about the design, what would folks characterize as some of the key criteria in terms of time to treatment and maybe stage of disease to think about in terms of implementing this in a study?
You know, if I could just make a comment, just from the glioblastoma side, if you look at, to answer maybe the stage disease, if you look at what we do for our patients, those patients come in symptomatic and we usually pour a ton of steroids into them from the beginning. So we start dousing the fire and then we take them to surgery. And then after surgery, we treat them with temozolomide, which is notorious for being lymphodepleting. And then we give them hyperfractionated radiation and we mix in more steroids. So in some ways, I always tell people it's like taking a diabetic, giving them a 12-pack of soda and then trying to give them insulin and saying, why isn't it working? I think what we've been doing at this clinical stage is that we're setting the immune system up to fail. So I think oftentimes we're going to have a hard time finding a signal with this particular tumor. And our hands are tied because the Stoop protocol, which this was derived off, did show benefit. So, and then we've tried taking, little baby steps, and we've taken the unmethylated MGMT population, and we've decided to go through and we held back the chemo, hoping that maybe with the hyperfractionated radiation, we'll be able to avoid some of this lymphodepletion. I mean, avoid some of this immunosuppression. And the readout from the 498 study, suggested that there was no difference, which is the BMS large phase 3 newly diagnosed unmethylated study. So it may be a situation where we might have to just let go and see if patients, particularly with unmethylated or are willing to forego chemo and radiation and give immunotherapy a chance. But it's a controversial topic and something that needs this intense discussion. But that's an issue. And you talk about timing, and you wait to do it in a recurrent GBM population. And we've done a bunch of studies in mice and found that after you pour temozolomide into these mice, the myeloid populations and the memory T cells never really are the same. So again, it sets up questions on whether or not that's the right population. So for a cancer like glioblastoma, we have lots of dilemmas right now ahead of us in terms of trying to pick that optimal clinical situation to give immunotherapy a chance to work.
Michael?
Oh, Dr. Okada, would you like to make?
Could I follow up on your very
Please.
thoughtful, comprehensive comments on the issue for brain tumor patients? Yeah, I totally agree with you. At the same time, though, the temozolomide-induced immunosuppression lymphopenia, we may be able to take advantage of that for strategies like adoptive T-cell transfer. So I worked with Carl June to design EGFR-V3 targeting CAR therapy trial. And then surprising finding we had was the unexpected post-infusion expansion of T cells, transferred CAR T cells in patient circulation. Most patients had been with the temozolomide treatment had the recurrent GBM, so heavily lymphopenic, and then we didn't do an active conditioning regimen, which would be normally employed in other type of CAR T trials. But without that, we saw phenomenon like as if the phenomenon expansion of T cells, as if we had done like a lymphodepletion. So the naturally existing temozolomide-mediated lymphopenic status may have helped the unexpected T cell expansion in those patients. So my point is that in the setting of adoptive T cell transfer, that we may be able to understand, we may be able to take advantage of the condition based on solid understanding of the lymphodepletion status of those patients.
Can I ask, Hideo, did you notice an expansion more in the periphery or in the tumor?
Yeah, so that's a great question, Mike. So actually both. So our study indicated that number one, in periphery, we had expansion for up to like 28 days. The expansion naturally attenuated over time though, but also 7 cases, 7 of the 10 total enrolled cases, we had an opportunity to resect the tumor. And in a sort of like a window of opportunity fashion, surgery was done like somewhere between 10 to 14 days, I believe, post-infusion of the T cells. And 5 of those 7 cases, we found surprisingly high numbers of T cells in the tumor that was actually associated with lots of inflammatory signals, induction of PD-L1, IDO1, which are typically signatures of a local interferon gamma response. I remember Carl June called me in my office excitedly and says, hey, Hideo, the most recent cases we saw like GBM being like an inflammatory melanoma. So that was a surprising, but at the same time encouraging observation that we may be able to turn the cold tumor you appropriately described, this typical cold tumor, we may be able to turn it into hot tumor by applying novel cell therapy technologies.
Yeah, I mean, just to piggyback on what you said, there was a very neat article published in Nature, and I just saw it, otherwise I would have included it, where I think it was at UCSD, Dr. Wang, where they, apropos for this, they used focused ultrasound and actually made the soil better for CAR T cells in the tumor and actually
Yes.
got it wrapped up. So it's a really nice article too in Nature.
Thank you.
Important points. And I think the comment about steroid use and really monitoring that and thinking about combining it with immunotherapy is so critical. And in many of these patient populations, that is standardly given. And so working closely with the clinical trial team to modulate that. I mean, that is one of the things we've looked at in a pancreatic cancer study that we did, where we have seen a survival benefit with PD-1 inhibitor with Gem-Abraxane. And that's in contrast to previous clinical trials. And one of the things that we really looked at was the difference in steroid use that might explain it. Oh, and thanks, the link for the Nature papers in the chat there. So maybe going back to trial design, with the liver cancer study, I wonder, Dr. Vidal-Jové, maybe how did you decide on histotripsy as your mode of going into it? I mean, it was a very well thought through clinical hypothesis and really looking at the effects there. But that's always the struggle for me when I think of integrating focus ultrasound, is which one to pick and why.
The question is, how do we decide the type of patient or the histotripsy itself?
Why histotripsy specifically for the liver cancer study?
Well, I mean, I was working with the people from Histosonics, which is a company that is now, they have a very nice device that it's going to be, I mean, it was the first in human study, so that's why it was decided. So it was not the decision on my own. It was I was working on focus ultrasound for so many years, and at the end I found out that seeing what you saw in the different meetings, that histotripsy probably was more immunogenic than others. And when it came in handy that Histosonics came with his new device, and we were able to develop this sponsored study by them. And well, then the decision was what would be the best candidate for this study, what would be the best patients to do these indications, and we decided that liver probably was the best indications to start with, and that's why we ended up with this study.
Thank you. No, that I think it will be exciting to see the results from the different mechanistic findings with the hypothesis of increasing the tumor antigens and activating the CD8s, and then maybe thinking about combinations on how well you have the dendritic cell prime there to see if you need to bolster that immune response better.
Dr.
Well,
Vidal, go ahead.
No, we did the study in all our patients, the lymphocyte Q populations, either interleukin-6, PCR. I mean, we did some blood studies on immunotherapy, on immune values, and we saw, I mean, not very much. We saw differences. We saw that the immune parameters were going down along the days after the procedure, and there was no inflammatory markers clinically clear on these studies. So the difference between this type of ablation probably and other ablations is that it provokes a less inflammatory response than the others, and also this is important also compared to surgery. So when you do a surgery or you do an ablation that has to instillate the needle, you have an inflammatory response. And in this case, the inflammation values were very low.
Dr. Vidal, do you mind if I ask a question, Dr. LaVallee? You know, what I always think is interesting about so liver cancer is a very myeloid-rich or tumor. And so when you do these interventions, you know, one of the things that if you look at myeloid cells, there's so many ways to activate them, right? There's DAMPs, there's PAMPs, there's pathways. Nature developed this to be so central for so many immune responses. And when we all talk about modulating, we've done everything. We've done TLRs, and we're all trying kind of left and right. But what I think is very powerful with the histotripsy is that you cause damage and you activate probably DAMP, those DAMPs, and that probably is very immunogenic. And just curious to see if you looked or tried to connect dots with that. You probably did, but in terms of the immune response.
We didn't do it in this case. There were patients and we were not able to do biopsies during the procedure or after the procedure. We have projects that to do treat and resect studies when we will be able to make biopsies on this case. But I mean, my recommendation would be to look at the studies of Dr. Cliff Shaw from the University of Michigan. He has done a lot of studies on animals to show that, and he shows that you see that the DAMPs going very low in this case. So, but in humans, we haven't done it yet.
Yeah, great.
Jessica, do you want to make any closing remarks?
I mean, this is a great discussion. We can continue this after the break, and we'll have more time till the end of our time with us, with you all today at 2:30 to talk just more about our clinical, how we're deciding our clinical disease targets and how we're designing these trials, and are there things we should consider that everyone should be doing in their trials, that sort of thing. So let's just take the 5-minute bio break, and then we can come back, and all of you, plus again, we want everyone participating to feel free to engage in the discussion so we can have a more robust discussion after the break. Thanks.